Hi, everyone, and welcome to a new episode of the Global PAD Impact Awards, where we celebrate the trailblazers who are redefining the care landscape for peripheral artery disease. Today, we are thrilled to present the prestigious Overall Excellence in Multidisciplinary Care Award, a tribute to visionary leadership and groundbreaking collaboration. This award honors a physician who goes beyond the boundaries of traditional practice, championing a truly collaborative approach that unites diverse medical specialties. By breaking down silos and fostering an environment of open communication and mutual respect, this leader ensures that each patient receives a holistic and personalized treatment plan addressing every facet of their health. Imagine the power of a team where vascular surgeons, interventional radiologists, cardiologists, endocrinologists, and allied health professionals all work in harmony. Perfect world, right? Well, this is the reality our awardee has created, transforming patient care through innovative practices. Through their dedication, they have not only improved clinical outcomes, but have also advocated tirelessly for patient access to comprehensive care. Their efforts have led to measurable improvements in quality of life for PAD patients, reducing complications and enhancing overall well being. Today, we are celebrating a leader whose work exemplifies the spirit of unity in medicine, a true role model in the medical community. It is with great pride and admiration that we congratulate Dr. Liz Genovese from the University of Pennsylvania, the recipient of the Overall Excellence in Multidisciplinary Care Award. Please join us in welcoming her to accept this well-deserved honor, a testament to her unwavering dedication and visionary impact. Dr. Genovese, thank you for all you do to save life and limb.
Oh, thank you. That's very kind introduction. I really appreciate that. And, I think also congratulations are due to you. I mean, the program that you have built and the patients that you reach out to and are able to help guide in the right direction is really remarkable and has made a huge impact. So I am really honored by this and appreciate the opportunity to be with you guys today.
Thank you, so much. I can't do it without amazing doctors, like you. And, you know, doctors that are so incredibly passionate about what they do. You can't be involved with PAD without immense passion, and that's usually driven from somewhere. So, what sparked your passion for treating peripheral artery disease, and how has that passion evolved over the years? Because PAD is not sexy.
No, it's not the sexiest field, particularly when you go through a training where I have experienced all facets of vascular surgery, where there may be some more exciting, sexier niches to get into, but um, it is one of the most rewarding fields that I have ever been able to be part of and experience. The impact that you get to play in patients' lives, the good, the bad, and the ugly of it all is really remarkable. And if you are dedicated to PAD, the way so many of my friends across the country who I learn from, who I grow from, and who I inspire from, we all become their physicians. We're not just their interventionalists or their surgeon. We are taking care of everything that goes into how do we get you from a wound on your foot that can't heal to you've healed and we've controlled your diabetes. We've gotten you to quit smoking. We've changed some lifestyle in addition to fantastic wound care and revascularization. We joke, we're like, well, the revascularization is just such a small part of the whole process, right? And it is it's remarkable what you can see from day one versus 3 months later, the impact that you can make on someone's life.
I love that you say that because there are quite a few doctors out there and it's their choice. It's the direction they have gone. But they say, "Well, I'm just the plumber. The patient should only see me when they need a procedure." But I think they underestimate their power and influence on the
Yeah.
patient versus simply saying, "Hey, stay with your GP, stay with your primary care until you have a wound that won't heal, and then I'm just going to fix it and send you back to them." They don't realize the influence and the respect that these patients really have for the vascular surgeon.
Yeah.
And how much more of an impact that you can have on getting patients to comply with their medicines and to comply, especially with those lifestyle modifications, right?
Hmm. Oh, absolutely. I think my patients know the broken record in which every time I ask them, even if they have been smoking cessation for over a year, every single time I see them, how's the not smoking going? And, I try to be kind, and we all understand that smoking is a very difficult addiction. And it takes sometimes multiple times to be able to quit. But I try to create a space where patients feel they can be honest with me, and ultimately we work together on different techniques. So every time I see patients, I'm asking them about, how are we taking our meds? Are we actually taking our aspirin and Plavix? Are we really refilling our medications? Are we not smoking? And so I think the patients appreciate the importance of those things when their physician continues to touch on that when they are in their appointments, right? I think there's a little bit of idea of like, oh, it's okay that I smoke a little bit because my doctor didn't ask me about it, right? And so that's such an important part of being a vascular specialist for the PAD patient population.
I love that. So for those patients that are watching right now, I think it's fair to expect your doctor to and tell them, hey, ask me about my smoking. Remind them, ask me about my smoking cessation, ask me about my diet, ask me about my medications. Because
Yeah,
especially with where we're at with the cost of food and life and everything, there are quite a few patients that have come to us and said, I can't afford my
right.
medication. I say, have you talked to your doctor about it? No, I
Correct.
just stopped the medication.
Yep.
And I said, does your doctor ask you about those? They said they never ask them about the medication.
Yeah. Yeah. And in fairness to patients, typically patients with PAD or CLTI or limb-threatening disease, you're
Mm,
often on a lot of medications, right? And it's
yeah.
hard to know what's important and what's not. And the number of patients say, well, I'm taking 10 pills a day. Why do I got to take this additional medication? And I have found that medicine compliance is so highly correlated with patient education. And taking the time to sit down and explain why you added Plavix to an aspirin regimen, or why we're now on a blood thinner in addition to aspirin, or why that cholesterol medication is so important for decreasing inflammation in the blood vessels, even though your cholesterol isn't high, right? And so when patients understand why they're taking a medication as opposed to just being thrown at them, then it increases medication compliance. And when there's financial difficulties, we can pivot, right? We can look at other medications, we can look at pharmacy assistant programs, but you have to start that conversation somewhere.
And I'm curious, before we move on to why you also received this award, which is your collaborative approach to care. I mean, I could argue, I mean, patients, they need to be collaborators in their care, right? So that's really the start. But how do you get them to stop smoking? What is that conversation that you have? How do you explain to them why they need to quit smoking? What is the mechanism of action that you share with them?
Sure, of course. This is like I said, this is a routine conversation I'm having multiple times a day for different patients at different stages in their journey of quitting smoking. And the first thing that I educate them is that quitting smoking is by far the best thing they can do for their overall health, from a cancer standpoint, from a cardiovascular standpoint, from a limb salvage standpoint. And then we get into the deeper information data about intervening to save a leg or to reduce pain when you walk, that our outcomes are not going to be nearly as durable if we're still smoking. And we talk about scar formation and how sometimes people can get a scar on you get a cut on your arm. And some people the cut heals and it's a cute little scar, right? And some people you get a cut and it's this big, ugly, nasty scar that develops. And I explained to them that smoking in the setting of doing interventions on blood vessels promotes that big ugly scar to form in the blood vessel, because every time we touch a blood vessel, every time we try to balloon a blood vessel open, we put a stent in, even though we have such great technology that wasn't here 10, 15 years ago, it's still going to cause some degree of scar formation. And so when people start to understand that smoking is going to reduce the risk of not only their intervention remaining patent and open for a long period of time, but that potentially if it blocks off, it could make them even in a worse situation. People find motivation, and when they understand why smoking is so deleterious to their care. But then
Oh,
once you do that, though, it's also very important to have a little bit of motivational interviewing with patients to see why they smoke, right? So some people smoke out of habit, some people smoke out of boredom, some people smoke out of stress. And then you can get a sense of it, do people want to be cold turkey quitters and get rid of everything all at once, or do you need to help develop a program to wean them down and then provide them with those tools? Because there's a couple different ways you can get to that point, but figuring out how to set them up for success, while can sometimes be a lengthy conversation, that first go around is pays off in spades down the road.
yeah. The fact that you take the time and that you care and that you follow up is really important to the patients. And it definitely
Yeah,
has that impact on compliance.
yeah,
And so we've gone through patients, they need to be the collaborators along with their surgeons, right, in care.
yeah.
But you have a grander approach to collaboration for PAD care. So I want to talk about, in general, what collaboration in PAD care truly means, why it's important. And then I want you to loop your collaborative approach to pad care into the conversation, and what does it involve?
Yeah. Well, I will tell you, this is, if there is a team approach to a medical problem, like this is it. I think we forget that it's, particularly when we get in our own little silos, that it's not just about bringing blood flow. It's not just about wound care. It's not just about diabetes control or medication compliance or smoking cessation. It's not just about being on the right antibiotics. It is a interplay of all of those, but it's not only an interplay of all those, it is one that is seated in an environment where there's constant communication between all of those pillars, right? So there are people who have access to great wound care centers and great vascular surgeons or interventionalists, but they're seeing them in two parallel pathways, right? Where they're not talking to each other and they're not getting updates about how things have changed, how things have modified, or where we're going wrong or where we're going right. And so what we have built at the University of Pennsylvania is really this collaborative approach where we are constantly revisiting patients and their current status of what is their revascularization status, what is their blood flow to their leg, what is their wound status, how are we changing their weight bearing status based on what podiatry did or what orthopedic surgery did, and what did the wound culture show. So now we loop in infectious disease. Well, we didn't have any positive wound cultures the last time, but we did before. Does this allow us to take someone off of IV antibiotics, or do we need to admit them and put them on IV antibiotics because something has changed, right? And so there's constant feedback with each other, both in the inpatient setting and in the outpatient setting, which can sometimes be even more critical.
I'm almost imagining all of you sitting at the table with a big stack of folders of patient profiles and saying, okay, case number one, who's this person? Everyone's powwowing. Is that
Yeah.
kind of what this is, what you do?
Very, very similar. The model I kind of took this after is, there's some other programs across the country that do this, but also the cancer algorithm, right? The oncology world where they sit down and it's radiation oncology, it's oncology, it's the surgeons, and they're all talking about the different aspects of this patient to develop the best care plan for that patient. And that's what we do, right? I have an incredibly close relationship with my podiatrist that I work at my hospital, my two podiatrists, and our infectious disease colleagues and our diabetic colleagues. We are always bouncing ideas off of each other. It's like, oh, I opened up the patient's arteries in the above the knee and at the knee. There's a little bit of disease in the arteries below the knee, but it looks like there's good blood flow. Let me know. And then they do their toe amputation. Say, well, it didn't bleed very well at all. So now I go back and say, okay, I got to go do more work, as opposed to saying, I did what I needed to do. You guys do your part, and we'll see how the patient's doing in 3 months, right? So it's a very different approach where we're all just kind of looking at the way to create an individualized plan for any given patient to try to get them to wound healing and limb salvage.
Can you share a memorable patient story where your collaborative approach helped to actually save a limb from amputation?
My God, and it's like my
A
weekly
million.
basis. I know.
That's a
you
really
know,
good thing.
I where I trained, I did a lot as a vascular surgeon. I did a lot of my own podiatric care. I didn't have the luxury of working with podiatrists on a regular basis, and the foot and ankle surgeons at my training institution were horribly busy with all kinds of other things. And so I learned from my attendings, and I do some great podiatric work. But when I came to Penn, I got the privilege to work with some really fantastic and innovative and young, aggressive podiatrists. And I remember getting a patient when I was like here for like a month, and the patient had an infection in the bone of the heel. And traditionally, I was always taught, and I kind of always practiced, is once the infection got to the heel, there really wasn't a chance at limb salvage. Sometimes you could do prolonged IV antibiotics to see if it could work, but really wasn't very successful at it. And one of my partners, Dr. Brunel, said, "Oh, no, 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 no. What I'm going to do is you revasc them, and then I'm going to remove part of the heel bone, and then I'm going to do this flap, and then we're going to put them in this really fancy shoe that I still to this day don't know what this shoe is, but it completely offloads the heel, and they're able to walk, and they're not bed bound for the next 3 months." And hand to God, that patient healed in 3 months. And 6 months ago, prior to being in that collaborative model, I would have offered that patient a below the knee amputation, maybe a trial of IV antibiotics, but knowing that just IV antibiotics alone really wasn't going to be sufficient. So having that approach where people are constantly bringing innovation in, I think is important, right? We are so lucky to be in a field where there's constant innovation, right? Whether it's new flaps, new surgical approaches, but the technology that we get access to as vascular specialists and vascular surgeons is very exciting. And, it doesn't always work, right? But it's important that we try, and we try to give our patients kind of the best contemporary care possible to see if we can get patients through it.
And I love that through this collaborative approach, instead of giving up on the patient, you give up the patient in a sense. And it's in
Yeah,
a different way. You have the conversation about the patient, and you're saying, you know what, this really sucks. Who wants to amputate a patient? Who really, in some cases, you can argue amputation is treatment, but for the most part, I think amputation overall is a failure of the entire system. Whatever it might be, right? For when it comes to PAD, and that even goes back to lack of early diagnosis. We're going way back
mhm,
there. So it may
yeah,
have nothing to do with you. You're sitting there, and then suddenly they present with wet gangrene, and you're like, yeah, okay, this one's obvious. I hate that. This is treatment. Amputation is treatment right now.
right,
But
right,
overall, again, failure of the system. But
right.
I absolutely love that you are willing to be so open, to having that conversation. Have you ever felt any sort of resistance, in your collaborative approach, in your efforts, to collaborating, to saving a limb in a collaborative way?
It's interesting you say that. I think that there are some people who are fairly set in their ways, right, and have an approach to PAD and limb salvage, and that's hard to change, right? But I think if you surround yourself with and collaborate with and bring people in the fold who are passionate about it the way you are and who want to learn, whether it's from within their own specialty or from other specialties, then you have the opportunity to constantly learn, constantly evolve. And one of the things that I have really enjoyed in my own career in the past 3 to 4 years is being fortunate to be part of a number of multidisciplinary conferences, whether they're regional or national. And every time I sit on a panel with interventional radiologists, vascular surgeons, interventional cardiologists from around the world, right? And I hear or see what they're doing, I'm like, I never would have thought of that. Or sometimes I say, well, that's interesting. I'm probably not going to do that. But it's still just being open minded and trying to take tidbits and approaches and seeing how that fits in your own algorithm and how that applies to your patient population, right? Because the patients that folks in the Southwest are taking care of are not the same as the Northeast, right? Different demographic, different comorbidities, different patient profile, different socioeconomic barriers. But when you are in those scenarios where you're learning from like-minded people who all are very passionate, who want to learn from each other, then that's where the real fun begins. And that's when people start to think of it as a patient first approach as opposed to a my patient or my specialty or a weird ownership that hinders the best care possible for the patient.
So, loaded question. How do you handle the tension and turf wars that sometimes arise, often too often, between different medical practices regarding who, in fact, should treat PAD? I'm faced with it every single day.
Oh, I'm
And
sure.
I play neutral. I'm just about the patients, and they have different access to different practices depending on their insurance, their geographics, their financial situation. And so we have to just play with who is the most skilled in that vicinity or that meets that patient's, immediate needs. But I have patients that will come back to me and say, this doctor is bad mouthing this other doctor and this other practice. And I feel this all the time. And I'm thinking, all of these doctors, I truly believe in my heart of hearts, every single one of them I talk to, whether they are advanced limb salvage specialists or they argue for their own limitations and only treat to the knee, they all actually really mean well. They
Mhm.
really have the best intentions. And so I don't think that there, in my experience, I don't think that there's any need, and especially with so many patients to go around, that we can't even get immediate appointments. We have a gentleman who's on here right now in our live studio audience who we can't even get into a limb saving procedure in his area for another
Yeah.
month
Oof. Yeah.
because there just aren't enough doctors to go around.
Correct. Oh, correct. And this is such a, it's a little bit heartbreaking because the person we should care about is the patient, and it's not about a specialty or it's not about feuds or anything like that. I get a lot of second opinion patients, right? And the one thing that I always try to emphasize to every patient who comes to me for a second opinion is I do not know the clinical scenario, the clinical presentation you had when you saw that other doctor, right? I don't know if I would or would not have made the same decisions. And ultimately, there's nothing we can do about that. We just have to say, where are we at now? And what do we do moving forward? Because that's the only thing that's in our control. Right. And I will tell you, if there was one right way to do any of this, we would all be doing it that way. Right. But there's often a plethora of different ways that we can approach a patient, approach a lesion, approach a revascularization plan. And so I always personally just try to be very respectful of people who are being sent to me. And even if they're being sent to me from, interventional colleagues, right, who are like, can you evaluate this patient for probably an open procedure? In or I'll have patients where from a surrounding area. I had this a lot more when I was in the South, where you'd have kind of a little bit more kind of traditional old school vascular surgeons who said, okay, I know how, I do aorta bifem bypasses, I do fempop bypasses. But when we start tinkering below the knee, it's just not my jam. It's not what I really like. And so I've always tried to be very respectful in my education to them about potential options. And I always refer patients back, do you want this in? And then ultimately, if you create an environment of respect and conversation and education, then you'd be surprised that the collaborative cross hospitals, cross specialty, cross the state relationships that you can develop that really fosters just creating the best plan for the patient.
I love that. I had a conversation with Dr. Jacqueline Majors, who's over in Tennessee a few weeks
Yeah.
ago, and she was saying that in order to make sure to continue to encourage other practices like interventional radiology or interventional cardiology to send the patients to her for more advanced work, um, she always makes sure before that patient leaves to ask them when their follow-up appointment is with their other doctor, and
Yep.
she sends them back to their other doctor so that they become an actual collaborative team, a
Right.
comprehensive team, as what you're being honored for today
Yeah.
in your efforts. So, what advice would you give to other physicians looking to implement a more collaborative approach to patient care?
Whew, I could write a novel on this. This is
Yes, please. I'm taking notes.
so I would say the first thing is that whenever you're going into a situation and you're trying to create cross collaboration, a multidisciplinary program for the PAD patient population, you got to learn your politics, right? You got to learn who is invested in the space and who is taking care of that patient population. Are they doing it alone in a silo? Are they collaborating with some people? Who are the referral sources? And how do you bring people who are siloed into the fold? And I try to, in any given specialty, so podiatry, interventional cardiology, infectious disease, I try to pinpoint one human who is insanely passionate and crazy as I am about the field, right? So if you get that partner in it and who really wants to learn, who really wants to innovate and create that cross collaboration, they bring their other partners around, right? Let them do the heavy lifting of some of the more traditional conservative folks in their own silo. But I think once you kind of learn those interplay and then bring everyone in, and whether that is an educational series, grand rounds, talking to their teaching their residents, cross collaboration from an educational standpoint versus let's create a monthly case presentation to start that dialogue, right? If it's a little bit more contentious, let's be respectful and let's talk about different ways that we would approach it. And maybe they may say, oh, maybe we say, oh, that interventionist isn't totally crazy. Like, yeah, I don't think I would have done anything different either. And they may say, oh, wow, that was a really innovative bypass. I wouldn't have thought of that, right? And so just starting to talk to each other, see the different approaches, and then that can progress to something along what we've built at the hospital of the University of Pennsylvania, which is a multidisciplinary limb salvage service.
Have you had any disagreements that have stood out that you've had to overcome? I know,
Perhaps.
I'm putting you on the spot.
And, yeah, yes. I mean, obviously, there will be some kind of staunch disagreements. And what I try to do in those moments is think about, is the disagreement really going to impact the patient, or are both approaches reasonable ways to treat a patient? And if they're both reasonable ways, just different approaches to treat the patient, then I do a little gentle education on my perspective and then let it go. Um,
Yeah.
if I think someone's really not offering the gold standard of care or a disadvantageous procedure, then I stick my ground when it's time, But I
Yeah.
still always try to do it in a very calm, respectful manner. And about half the time, people come around to it. Sometimes they don't, but that's okay. We just keep working at it.
Yeah. I mean, I'm even looking for some advice on my part. I just had over the weekend, I had some general surgeon fellows who I was educating them on the need for a proper vascular evaluation, even prior
Yeah.
to a toe amputation for a type 2 diabetic.
Oh,
And they
absolutely.
kindly, exactly right. And this general surgeon fellow came back to me and said, we're not required to follow Society for Vascular Surgery guidelines. And I said, well, it's part of AHA guidelines and it's part of 2024 PAD management guidelines for lower extremity PAD. And he said,
Yeah.
well, we're just not required. And I said, okay. It got to the point and I had to take a deep breath. I'm like, I gotcha. And I had to get to the point and say, well, what do the bloods look like? Is there any infection in the blood? How do the white blood cells look? Turns out the osteomyelitis was actually isolated to the distal phalanx, and it
Oh,
was
good.
more chronic, right? Versus in there was nothing systemic about it. And
Yeah.
so I said, so what you're saying is you're planning to do an elective procedure and amputating the entire toe. How would your hospital administration feel about you doing that in the middle of the night on a Saturday night and not get reimbursed for that?
Mm.
Well, lo and behold, that did it. And it was just asking the question, just saying, Well, what would they think? It is an elective procedure at that point.
Yeah.
And ultimately, you'd respect this. We were able to get them out of the hospital and over to USC. And of course, they saved the toe. You know,
Yes.
did the proper evaluation and all that jazz.
Well, it always surprises me that when it comes to patient care, there's always an initial gut reaction practitioners have of, I don't want to be told I'm wrong, right? I don't want to be questioned. And I forget what podcast, I was listening to some podcast somewhere. I don't know if it was the CEO of Amazon, but he said, the first thing I think of when people say I'm wrong is, could they be right? And how often when you go to a physician or a care provider and say, I think you're wrong, do they say, well, maybe they're right, right? And so that's hard, but I really, ever since I heard that interview, I really try to take that in, right? And so when people come to me and say, oh, I don't want to give them IV, or I don't want you to put them on IV antibiotics before you do this procedure because it's gonna ruin my cultures, and my gut reaction to be like, no, you're wrong. I want to do it because they have a foot infection, and all, step back and say, okay, let's think about it. Let me see what their perspective is. Let me see what their difficulty is and their tissue cultures once they get that information and I've done my revasc, versus what is the risk to that patient if I don't do it, right? And then all of a sudden, both parties are educated. We're both walking away with a better plan for the patient than when we started the conversation.
Mhm. We have one of our in-studio audience members, I think that's Douglas, that just wants to give his gut reaction to your presentation so far. He says, wow, 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 wow. Um, we need to bottle all of your spirit,
Oh,
which is amazing. You definitely have a
I'm
contagion.
pulling into Lowe's parking lot, and I'm thinking, we need to. I'm gonna go in and get some bottles and send them to you, doctor, so that we can bottle that and pass that out around, because what I'm hearing is absolutely amazing as a patient to know that I had a conversation with trying to get some stuff transferred this morning with my doctor here to a doctor in Houston, and his nurse practitioner said he wasn't going to because I don't need a second opinion. He was right, and I don't need to go to. Yeah, I know, Kim. We'll talk about it later, but and
Wow.
so they weren't going to transfer my information to the doctor in Houston, and it was like,
oh,
please, ma'am, I'm just getting another opinion. That's all. And so apparently they're going to do it, but I ran into that this morning.
that's so sad to hear, because I will tell you, when any of my patients start to feel uncomfortable with plans, even if I've given them a couple different options, I always offer, please, if you want another opinion, please seek it, right? I'll facilitate that for you, because it is your body. It is not my outcome. It's your outcome, right? And I want every patient who walks into my OR, every patient who gets admitted under me, to know that they feel comfortable with that, right? And it's always your right as a patient to get a second opinion. You may still go back to the first person, but you want to be comfortable with that plan. It's your
Yeah, I
body.
told him when he goes and sees Dr. Miguel Montero Baker, I don't think he's going back. So that's his second opinion. I mean, here he is,
Oh.
a patient, Douglas, that he started out with stents, never diagnosed with PAD. And then they did an aortobiofemoral bypass because they said they couldn't clean out the stents. This was 6 months later.
Yeah.
Still no conservative therapy, no medications offered, no lifestyle modifications discussed. And that failed within 6 months, go figure. And so they went straight to an axillary bifemoral bypass. So within a matter of 18 months, he's had stents, aortobifemoral bypass, axillary bifemoral bypass. And what do you think happened there without any sort of, dual therapy, or even a statin or lifestyle modifications? Well, that blocked. And
Yeah.
so, I think he deserves a second opinion.
Yeah. Well, and you're gonna love Dr. Montero Baker. He's a revolutionary in the field. So you're very lucky to be in the Houston area. So I encourage that.
I love that. I just talked to Dr. David Dexter, whom you may know out of the Virginia area, and there was a patient that ended up reaching out to me, and she was in the hospital. And of course, when they see in their chart something about amputation, their family members go awry. They go onto Dr. Google, they go everywhere and search, and they found me. And he was the head of chief of vascular, for the
Mhm.
department. And what was great is he actually reached out and said, "Hey, I hear the patient, it has questions or whatever with the team. If you want, I'm happy to even see her. I love my team. I think they're great. They are top surgeons. I mean,
Yeah,
he's built an incredible team there across Virginia.
absolutely.
But the fact that he's like, you know what, there's no egos here. Um, I'm willing to see this patient. I'm willing to give another opinion. Happy
Yeah,
to. And I might have a different option. And I love that. And I love
yeah.
that we're seeing more and more of that. And I hope that this conversation inspires more physicians to start more collaborative care approaches, such as what you have to offer and what they have to offer, which I think would be great.
Yeah.
So I want to talk about some technologies because you mentioned
Yes.
innovation. And innovation is moving at the speed of light with peripheral artery disease. And I always say, to a patient, well, today they might not have an option, but tomorrow you might wake up and they will. And so it's really good for patients also to stay up on it. But what are some of the innovative technologies or treatments that you are most excited about right now that are leading to more limbs being saved today?
Oh my goodness. It's like too many to talk about. I mean, we are in a renaissance for endovascular PAD care, right?
Yeah.
You start with drug elution to help decrease inflammation after your intervention to get our interventions to last longer, whether it's ballooning or stenting. I think that calcium modification, we have a lot of calcific disease, right? A lot of diabetes combined with smoking that produces this very rock hard bone like disease in blood vessels. And I think that calcium modification has really evolved over the past 3 to 4 years and has been a game changer with increasing durability of our peripheral interventions. And on the horizon is how we utilize deep venous arterialization and below the knee technology. I mean, this is really, I think, where the field is focusing. And we have a lot of exciting technology, bioabsorbable stents, different types of technology that modify the arteries below the knee, some that have little spikes that go into the artery that allow it to really kind of expand and almost like like you have little perforations on a paper to kind of like allow that to expand. They may be putting drug on that. This in the technology with regards to bioabsorbable stents is going through multiple generations of iterations. And so it's a very exciting field to be part of. And I think that the deep venous arterialization is a very interesting technology that we're learning a lot about its suitability. And so for people who don't know what that is a way to bring blood flow to the foot through the veins as opposed to the arteries. And that is because the arteries in the foot may not be present anymore. So traditionally, whenever I would do a bypass, I would bring blood flow from one artery above to an artery below a blockage, right? And usually some artery, whether it's a little wisp of something in the foot or right around the ankle, kind of pops back up, right? It reconstitutes for a little collateral blood vessel. So it's something I might bypass to, or it's something I might get a wire into and then balloon or stent to get blood flow straight into the foot. In patients who have this disease where it's eating away and it's collapsing all the arteries in the foot itself where there's nothing to plug into, nothing to get to, then this is a new exciting way to bring blood flow to the foot. It is a process. It is a 2 to 4 or 5 month process, and it takes an incredible team between podiatry, the vascular interventionist, the vascular surgeon to get you there. But I think, a game changer for a lot of patients.
Oh, we've definitely had it, but there's still a very serious patient selection that has to go on with it.
Yes.
Patients, I try to let them know that yes, it might be available, but are you the right candidate? And I'm not saying not because it can't be done, but are you the right candidate with the right grit and you have time and you're willing to make it a priority as long as it takes over the next few weeks, one, you got to deal with increased pain. You got to deal with an increased, very vicious wound.
Yep.
And there's a lot for you to be a partner in your care, and a lot you have to withstand to get through it, to
Right.
get that wound healed, and then to get back on your feet and start growing those collateral vessels, right?
Oh, exactly. I have a patient that, it pains me to say that I recently did an amputation on, and it was, an older gentleman who had been dealing with a wound on his heel for 9 months. And in
Mm.
addition to that, he had had rest pain for 9 months. He hasn't slept in 9 months. I did an angiogram on him. Anatomy wise, a beautiful deep venous arterialization candidate, complete desert foot, nothing that I could recanalize in the foot. Had a couple different options of ways to bring blood flow through the veins to him, but he hadn't walked in 4 months. He was exhausted. He didn't want to come back to doctor's appointments, and he was already dealing with a significant amount of pain. And in that patient, that wasn't the right thing for him, right? Could I technically have given it to him? Absolutely. But when you with deep venous arterialization, you have to get to know the patient. You have to get to know their family resources, what their life is like at home. Are they able to get back to you? Because the worst thing that you could ever do for a patient is do a deep venous arterialization and then send them out into the wild, because you can have that increased pain, increased swelling, wounds can get worse, and you need to be able to offer them repeat angiograms to kind of force more flow into the foot, pretty aggressive wound care, things like that. And so you're absolutely right. It's a huge patient selection.
Yeah, we are really big into those conversations with patients. I'm even having one of those tough situations right now. We have a patient that was at an HMO system here in California, and they were just trying out Phillips tax, and the
Mhm.
doctor didn't know how to use it. Literally, there's my dog. Literally more than a dozen tacks, including below the knee, that weren't even the right size, didn't even use intravascular ultrasound to ensure proper sizing and placement of these things. And so she is young, in her 50s, and just keeps reoccluding like every 6 weeks. And at some
Yeah.
point, you have to just say, you know what was done was done. And what's your quality of life? And she asked me the other day, she said, is it time to just move on with my life? And sometimes you have to, say that's a really good conversation to have with your doctor.
Yeah. And one of the privileges I get to do as a vascular surgeon is that I get to walk patients through that whole spectrum of, the process of their PAD, right? And so I get to do the endo stuff, I get to do the open stuff, but to me, it's very important that if we do get to the point where we are discussing and performing a major amputation, I'm very privileged to do those amputations for them. And um, I help coach them through that process, because it is very, very difficult to come to terms with the fact that you're going to lose a limb, right? And I think it's critical to have a physician who is on your side, who understands how difficult that is for you, and kind of be your cheerleader through that process. Because if you don't have the right mental attitude going into it, the right kind of approach, you can just become deconditioned. And it's the difference between walking with a prosthetic and going back to having a normal life versus kind of losing your independence and losing that ability to keep up your quality of life.
I love the way you phrase that, because, if someone is, having that amputation, to have someone like you, um, to be there for them, we don't see that all the time. And in fact, the general surgeons in the story I shared with you before, when the gentleman signed the paper to go through with the amputation, they actually cheered. The fellows cheered. He said that's when they actually thought, wait a minute, something's odd. And
Yeah.
so that's when they went online and actually found us, and we were able to jump in and advocate and ask the right questions. But
Yeah.
you think it's surreal that this would happen, but
Yeah.
it did. And it's not only a matter of finding the right person to, revascularize, whether it's minimally invasive or invasive, but also the right person for that amputation, because it is a very emotional
Absolutely.
experience.
Right. No, absolutely.
And that's what, Douglas jumps in and he's like, yes, I'm still a human being. And that's really important. I want to address a couple of really tough questions before we just go into our final few questions here. And thank you so much for spending so much time. But I feel like you're the right person. There's this big debate about the use of devices and uses of innovation. And I actually cut my teeth on, um, you know, peripheral artery disease in Italy with Dr. Marco Monzi and, a bunch of the other doctors there in these other countries, that they could do amazing things with um, just wires and balloons and with a less is more approach. And it blew my mind how far they could go with just those tools. And when the debate over atherectomy, the roto-rooting devices, started occurring, I went to Marco Monzi and I said, I traveled the world following a medical device that was one of those roto-rooting devices, a laser.
Right.
And I saw all of these devices used and, at different times. But at the time, I really felt like there were strategic discussions as to when and how those devices were used. Number one, in, the Achilles heel of the SFA, when there's just calcium upon calcium, a little bit of orbital atherectomy is indicated. If there's in-stent restenosis, well, then a laser may be indicated to remove some of the yucky stuff in there. But I do find that there really shouldn't be a debate over it. I do see instances where I'm like, did they really do it? If Marco Monzi can do it, and if Dr. Raman Varco, vascular surgeon in Sydney, Australia, has said yesterday during our interview, he very, very rarely amputates. If he can do it, then why can't we?
Yeah.
And
No.
I don't understand, and I'm curious because from your perspective, what are the questions that patients should ask? And because of that whole debate, I always say to the patients, it's important, honestly, to know what tools your doctor's using and why they're potentially going to use them. What questions would you have them suggest they ask to ensure that they're not being over-treated?
Oof, that is such an interesting and tough question to answer, but I totally agree with you. It's funny you bring up Marco Manzi, because I spent some time with him shadowing over there, and I was like, all he did was balloon. That's all he did.
Right?
In Japan, a lot of just angioplasty alone, right? And so, unfortunately, the American healthcare system has made it that such that expensive technologies are reimbursed, that it covers it if you do need to use it, so you're not underwater with it. But ultimately, the reimbursement process has led us to be vulnerable to maluse of things for financial incentives, and it's not specialty specific. It's there are going to be people who overuse things for the wrong reasons, and that's unfortunate, right? And not to say that there's not reasons when we do use atherectomy, right? I don't use atherectomy a ton. Some of it, I think, is, for example, a stent that has in-stent restenosis. Laser atherectomy over filter and some drug in that situation has very durable outcomes. There's a lot of data to support that, right?
Something that added the filter.
Yes. As a vascular surgeon, I try not to burn any of my future bridges, even if they are bridges of taking arm vein and piecing them all together and going somewhere very distal. But routine use of atherectomy in every procedure you're doing, I do not think is justified with data that's been done, and I don't think that is right for the patient, because every time you add a different part of a procedure, you put them at risk, right? Potentially of hurting the downstream blood flow, of hurting the arteries in the foot. So we want to make sure that what we're doing is for the right reason, but you don't want to throw the baby out with the bathwater, right? Like, there are absolutely clinically indicated reasons why you need certain types of atherectomy devices. And I have a little tool bag, right, that I use. And sometimes I balloon something at restenosis. Maybe I need to use one that shaves on just one side to kind of get things to open up. Sometimes I need to use a laser. Sometimes I need to use something that sucks kind of fresh thrombus and kind of that junk out all at the same time, right? It's there. So I think that, to circle back to your question, which is, how do you advise patients to talk to their physician about kind of technology that they're going to use to kind of get a heads up if someone potentially is someone who might be an over user of certain technology for financial gain? I think I would just talk to them about what they expect to do during your procedure, right? And if someone automatically is like, absolutely, it's your first angiogram, I'm going to balloon you, I'm going to atherectomize you, I'm probably going to stent you, just take that in context, right? If someone talks about, a little bit of a conservative approach, but these are backup options, then that makes me feel a little bit more comfortable, because you also don't want to engage with a practitioner who ultimately isn't going to give you the latest technology either, right? So it's an incredibly fine line to walk between that. And so I like to offer tell my patients that, like, I'm going to do what's safe. I'm going to do what will allow me to keep an open procedure down the road. But simultaneously, I'm going to give you all of the technology at my disposal, which means I'm going to use intravascular ultrasound to look at the blood vessel from inside of it, so that I know I'm doing the right thing and I'm done with my procedure when IVUS says I'm done and not when my angiogram says I'm done. I'm going to use drug elution because the data behind it is so strong that it has such increased durability in the 2 to 5 year mark, right? And so that's what I talked about to my patients. Typically for me, atherectomy is not my first go-to part of a procedure, but that is also my practice pattern. It's a hard kind of thing to elicit when you're meeting a physician for the first time.
It is really difficult. And I understand in patients that are on deck for amputation, CLI patients, sometimes you have a little bit more room to be more
Right.
aggressive. But,
Correct.
for the most part, our philosophy, and from what I've seen from traveling to nearly a dozen countries, more than 30 states, the best outcomes I've seen is really with that less is more approach. And even with atherectomy, the ones where I felt like we saw the outcomes afterwards, they did it right. Well, they weren't trying for maximum luminal gain. They were
Right.
literally, you know what, I just need a little vessel preparation because I want to
Right.
use less balloon pressure because the vessel's very fragile. So
Right.
that's what I'm going to do. But I've seen them where they've gone back and forth and back and forth, and you see the outcome in IVUS, and there's flaps, the dissections, and then of course they have to do a bailout stent.
Right.
And the whole goal is less is more. Tiptoe in. I tell the patients, kiss it with the balloon, see how you react. But we still have doctors that will tell the patient, I'm going to do a stent procedure on you.
Yeah. That's tough too, because I think sometimes it's just the way that physicians have learned to communicate to patients. I forget sometimes, like I'll be like, oh, well, we'll balloon the artery and I potentially need to have a stent. And it's one of the conversations I have when I talk to patients who come to me for claudication, right? So in the limb salvage world, in that you have a wound that's not healing, or you're up all night because you have breast pain, you're at a 20-25% risk of limb loss that
Right.
first year. We're going to go all out on getting you blood flow so you can heal, right? Claudicants, 70-80% of patients won't progress to that end stage of it, right? They'll stay at claudication. And so in addition to medical management, a walking program before I even offer them anything, once I get to that point, what I start talking them about is, well, I'm going to balloon your artery. But the moment I put a balloon in the artery and I open that artery up, you're going to be at risk of getting a stent. Because if I open it up and it looks horrible, no matter how careful I am, I'm going to have to put a stent in. If you get a stent, you're my patient for the rest of your life. I'm always going to have to follow that stent. You're always going to have to be at least on one, if not two, antiplatelet medications. And people appreciate that conversation, because sometimes people just like, oh yeah, we'll fix you, we'll make you feel better, but they don't understand the long-term ramifications of that. And some people are like, you know what, if it means a stent for the rest of my life and I got to see you, once every 6 months or a year, and I got to worry about it re-narrowing, they're like, I'm okay, it's not that bad, I'm going to continue your walking program. Now some people are like, my life is miserable, I I can't get to my mailbox. I can't walk through the grocery store. That's a totally different scenario. It's a totally different set of risk benefits, right? And then we move forward.
Yeah. And
No.
we always say to our patients as well, we add in that, this isn't a cure, that literally the less is more approach is better, because all you want, and I tell them to say to their doctors, you can always correct me if I'm wrong, because, your mentorship, that of all of my board members and other doctors, is really what's important to me, because
Yeah.
I need to appropriately guide them. But I always
Yeah.
say to the patients that these procedures, and you can say to the doctors, say, hey, less is more. I just need that much more blood flow to get some symptom relief so I can
Yeah.
get out and walk, walk, walk.
Right. Absolutely. It's really interesting. One very perfect example of that is when patients have common femoral artery disease. So when you have blood flow going into the leg, right in the groin, there's a key split between the arteries. One is an artery that goes to the side that gives lots of really, really important collaterals. And then one is the artery that goes straight down the leg. And so I will sometimes see patients who it hurts when they walk, where they have common femoral disease. And then they also have SFA disease, or the superficial femoral artery, which is that artery that goes straight down the leg. And so often, what ends up happening is if I just clean out that common femoral artery alone, 9 out of 10 patients, their symptoms are so much better. And when we do a femoral endarterectomy, an incision in the groin, clean out that artery, put a patch on it, what ends up happening is that it is a very durable operation, things that can last 10, 15 years without any problem at all. Versus if I start going down, also simultaneous treating the superficial femoral artery, now that's something where I'm looking at durability of the procedure over a 2 to 4 year time period, as opposed to a 10 to 15 year time period.
Mm-hmm.
So what I often offer my patients who claudicate is, let's do the femoral endarterectomy first. I won't burn any bridges. I'll make sure I can get into the SFA endovascularly if I need to. But if I can get you to feel better with just this and without giving you an additional procedure that has less durability, then we've won the game, right? And like I said, 9 times out of 10, people are like, this is great. I feel great. I never want to see you again. Now there's always a patient or two every year who comes and they're like, it's still really bad. And then we go after the SFA, right? But we know that we've tried to do the more durable, less is more kind of procedure before diving into the other stuff.
Well, you can grow so many collateral vessels around there, and patients are
Right.
amazed. They actually, some of them ask me, well, can I get a CTA to prove it? I'm like, no, less is more. Again, they can actually, you can see the improvement in your ABI and your
Maybe
ultrasound.
Yeah.
And you can just imagine those collaterals at that point, which is good. But
Yeah.
looking ahead to the future, what are your goals for
Yeah.
continuing to advance PAD care and promote collaboration across specialties?
Yeah, I mean, I think it's just for me, I've been at the University of Pennsylvania for about 2 years now, and it's just continuing to build on this model and grow it even bigger. One of the limitations that you have in building a multidisciplinary limb salvage program is there's some financial constraints, right? This is a lot of upfront heavy cost in the beginning, right? And so it's about studying your data and proving to the C-suite and administration that upfront this multidisciplinary care that requires a lot of resources from multiple different service lines really pays off in spades down the road for the patient. Less hospital admissions, less wound complications, better limb salvage rates, less time in the hospital. And so for me, my goal is to continue to bring in that contemporary, innovative endovascular care while simultaneously building the program. So I'm so excited to see, let's talk again in 2 years and see where we're at. And I'll give you the interval update. But so far, we've made a lot of progress in the last 2 years.
I love it, and I hope other physicians and healthcare systems actually watch this and are inspired by you and want to replicate your program. Our final few questions here. Share a case that had you just scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. It's our Journey to Diagnosis series.
Yes, the journey to diagnosis. I wish I could say that this was an infrequent kind of experience that I have had, but it is not. This is probably something that I see at least once a month, if not more frequently. One of the first times I experienced this in real life as an attending was when I was down in the South. And I had this wonderful older woman who went to her podiatrist, had gone to her podiatrist regularly in a very more rural area, and she got an ingrown toenail removed. And it started with just a small little wound where the ingrown toenail was removed, and they were doing local wound care, and then it festered, and then the whole toe became gangrenous, and they're still working on local wound care. And it took probably 3 months for there to be a realization that we weren't healing because of bad wound care, but we weren't healing because of inadequate blood flow. And this was a patient who already had a little bit of distrust of the medical system. And by the time she got to me, was very angry at the system, right? Like, I did the right thing. I went to my podiatrist. I'm doing everything they're telling me to do. And now you're telling me I'm at risk of losing my leg. Like, it is astounding the shock that people have. I mean, I get it when you think, oh, I have a wound on my toe. Now you're telling me I'm going to lose my whole foot. That doesn't make any sense. So, I think that in those scenarios, and we touched on this earlier this hour, which is most people actually are really trying to do what they think is best for the patient, and they really do mean well. I just think that there is some gaps in education and gaps in modern practice patterns that allow for evaluation of severe peripheral arterial disease to be missed, right? And then you combine that with decreased access to tertiary centers where you have aggressive endovascular specialists or aggressive vascular surgeons, and then it kind of sets patients up for this very delayed presentation to a limb salvage expert. Luckily for that patient, it took some time, it took some rapport building and some education for her to understand where we were at. And I was actually able to revascularize her, ended up actually with a bypass, but she healed a TMA. And I followed her for a 5-year period before I left the area, and still patent, but she was a tough nut to crack. She really didn't trust the system, and I understand why. But it's not an uncommon theme that anyone who does this on a regular basis will encounter.
Okay, 6 minutes that mattered in your career. It has to be a defining moment. What was that catalyst for change that sparked, that led you in a specific direction, conversation you had? Maybe it was a clip you watched. What was that moment that mattered for you?
This is an interesting question. And I'll give you a very honest answer. So when I was early in my attending career, and I really kind of transitioned to focusing on limb salvage, I had lost a resource of my nurse practitioner who was so helpful to me, really engaged in taking care of this patient population in the way I do, right? A holistic approach where we're giving them their statins, we're making sure they're medically compliant. It takes a lot of effort, right? And I lost that resource. And I went to higher ups and said, you have to help me replenish this. I need this to take care of my patient population. And words that were said to me were akin to, limb salvage is not that difficult. And what you're doing is really kind of out there. And you don't really need this additional support. And what the programs you're building are pretty unnecessary. And it was kind of one of those moments where you're like, okay, challenge accepted, right? And I put my head down. I dealt with the resources I did. I built a great program there. I opened up a wound care center. And then I came up to relocate to the Northeast to be closer to some family, and, came to a program that kind of with open arms realized the need for a multidisciplinary collaborative care model. In West Philadelphia, the rates of limb loss are astounding. And it's some of the highest in the country, and people are within a 1 to 2 mile radius of some of the best hospitals in the entire country, between Penn and all the other institutions in this city. It's amazing, but there's a lot of work to be done, and it's not just about blood flow, and it's about that multidisciplinary care. And I'm very fortunate to be part of an institution that really supports that effort.
It speaks volumes to your character, because I do get calls from some other doctors that just feel so beaten down and are
Yeah.
very frustrated. Any advice for them? I know I keep taking up more and more of your time, and but you are so amazing, and have so much inspiration to offer.
It's about finding the small gains and wins when you're not in an area, not in a world area where it's necessarily supported. It's about taking on smaller initiatives and making small gains. It's like I tell my residents when I'm telling them to write a paper and they're very overwhelmed. I said, how do you eat an elephant? You eat it one bite at a time, right? And so sometimes when you want to go and you want to do these sweeping changes and create this huge program, people balk at it, right? And so you look at it and you say, okay, here's my 10-year goal, here's my 5-year goal. What's my 6-month goal? My 6-month goal is actually just to get engaged with infectious disease and find a partner and get someone who wants to collaborate and maybe build some antibiotic pathways. And then you accomplish that. Then the back burner you have, okay, what's my other goal? I'm going to reach out to interventional cardiology. Maybe we're going to make a monthly case conference to start to see if we can get on the same page so that we're not fighting over patients, we're actually collaborating. And then maybe the year goal after that is maybe we start getting a half a day in clinic space where we can both see patients, right? And so we are having this collaborative model where we're optimizing them medically and we're both seeing them and we're talking about their open and their endovascular options. It's hard. It's a hard battle to climb and a hard hill to climb, but it's worth it. It's absolutely worth it once you start seeing some of those gains.
I love that. We do have a series called The Pulse, which is sharing the case in which you learned a lesson and others can learn from. You did share a case early on that I think was incredible. We can stick with that case, or if you have another that you'd like to share, you can let me know.
I'm trying to remember the case I shared with us earlier.
It was about collaboration. I asked you about the
Oh
collaboration.
yes. Oh, the heel.
That was
Yes.
amazing.
No, I think for me, a lot of my learning in the past 18 months has been with the deep venous arterialization patients. I think we're all learning right now, and anyone who tells you that they have the algorithm down perfectly is fibbing a little bit, because this is a tough patient population. I think we're advancing the field more and more, and we're learning more and more of who we should be applying this to. And so I would say early on in my adaptation, I performed a DVA on a patient who wasn't very robust, right? He hadn't been walking much, but he would kind of get around his house. But he just looked frail, right? He was very skinny. He wasn't very robust. I was trying to like be a cheerleader and do everything I could for him. He didn't have pain. He just had a wound. So it's not like I knew I was going to make the pain worse. And within like 6 weeks of me doing it, he just really went on a downward spiral and ended up going into hospice. And I'm almost certain the swelling and the pain and the need for narcotics after doing that DVA expedited that kind of overall course of the rest of his life. And that's a really hard lesson to learn, because I was doing it for the right reasons, right? The guy begged me. He just wanted to save his leg, and I wanted to save his leg for him, right? And I think as I've learned what the course of this looks like, and I've learned to set people's expectations, and I've learned to say no to some people with it, just because they have the ability to do doesn't mean it's really the right thing for them. And that's been a hard lesson.
Depending on what the patient, say there's so many patients that say they want to die of dignity, with their legs. But even then, that's, especially in that case, that probably would have been an earlier hospice situation, to
Right.
maintain the leg and pass peacefully at home. So it's amazing, to hear you, be so honest about it, because it is a tough decision. I think patients need to realize that sometimes there are tough decisions that doctors need to make and need to be making. And so that's amazing.
Yeah.
Okay, finally, walking is
Yes.
medicine.
Walking is medicine.
It's our number one priority, with the Global PAD Association. We want you to just share, if you can, share a story of a patient where walking as medicine changed their life. And then I'll ask you that second question about how do people walk effectively to grow those collateral vessels?
Well, I think I'm going to expand on walking as medicine. I'm going to be controversial here. I'm going to say walking and food is medicine, right? I think that nutritional status and exercise is so important to our patient population. Yes, we have walking in the sense of walking to build up collaterals, to get around blockages in the femoral artery in the thigh and behind the knee is critical. And that is one degree of walking. But I will tell you, walking is so much medicine once you've had an intervention as well, whether it's a bypass, whether it's an endovascular intervention, because conditioning is just so important in our patient population. Because what we forget is that people come in and they've been smoldering along with this vascular problem, right? The moment we start doing things, whether it's an endovascular intervention, a bypass, a foot debridement, you keep them off their foot for 6 weeks because you're trying to heal a TMA. All of a sudden, all the other things, the deconditioning, that may be kind of underlying, the other comorbidities, the malnutrition, it all starts to become so much more prominent. And it is the difference between people staying independent and staying out of a nursing facility and being able to go home and being able to continue their life outside of the hospital versus going down this spiral of I'm in bed, I'm not getting up. Now I'm going to need to go to a nursing facility. I can't go home. I'm in a nursing facility. They're not working with me enough. And it is the spiral. So yes, walking is so important for claudication and to building up those collaterals. But my goodness, once an intervention is done and you can put all the weight on your foot you're allowed to, it is so important maintaining your overall physical health and healing your wounds and getting you to a point where you maintain your independence. Because why do we save legs? We save legs to use them, right? And we've done everyone a disservice if we haven't focused on maintaining that physiologic stamina to allow you to use the leg we just saved.
That was well said. Well said. Thank you so much. I appreciate you so much. If you wanted to share, actually, how does it work? How does walking actually grow these collateral vessels? How does walking improve claudication?
Yeah, so when we have blockages in the arteries, particularly after the common femoral artery, right, in the middle of the thigh, behind the knee, we have that one artery that I talked about that goes off to the side called the profunda artery. And it, along with some blood vessels in the pelvis, can provide very important little smaller pathways around a blockage. And when you walk and you have your muscles cramp because it hurts because it's not getting enough oxygen, your muscles are sending off signals to the body, I need more oxygen. I need to build new pathways around the blockages. So even though it seems counterintuitive, when you walk and you cause that cramping to happen, your body you're actually promoting your body's own way of finding pathways around those blockages. And so the way I educate patients is okay, as long as we have those kind of pathways set up in place, meaning there is blood flow into the profunda artery, there is good pelvic blood flow, we have a scenario where we can walk and get improvement. So I tell patients 3 to 5 days a week, we got to walk. But you don't walk and then it starts to hurt and say, oh, okay, I'm done, right? Like you got to walk through it a little bit because you need those signals from your muscles saying, oh, I need more oxygen. You need those signals to tell your body, I got to make more pathways. And they're not perfect pathways. They're all these little squiggly pathways, but it's enough to overall increase the pressure of blood flow to your muscles that you potentially could get to where you don't have to stop for 30 minutes. And maybe you can't walk for an hour without getting claudication. But for a lot of people, if you can get to that 30-minute period, you can do everything you want, right? You can go for the walk with your grandkids. You can get through the grocery store. You can play pickleball. Pickleball is a new thing that everyone wants to not claudicate for. But it really is a very useful way to get patients out of that claudication system because it's not like that is at risk of going down. It's not like you're at risk of getting worse if you manage that conservatively.
Well, thank you so much, Dr. Liz Genovese. I just appreciate you so much for all you do to save life and limb, and a big congratulations to you for prestigious overall excellence in multidisciplinary care award. we really appreciate all you do to save life and limb and inspire others to do the same.
Oh, well, thank you so much. Thank you.